Hello, everyone. Thanks for coming and having lunch. Can everyone hear me? No, you can't hear me? Okay, good. You know, this is a hard space, so I'm going to speak really loud and then I'll keep moving. But thank you for joining us today. We're very excited to be here. My name is Linda Saplicki. I'm an advanced practice provider who specializes in advanced heart failure and mechanical support. And in my role at Abiomed, I'm responsible for developing our programs just like this to help raise awareness around the impact of temporary mechanical support on saving patients' lives. And for all of you here, I hope that's one of the reasons that you joined this session and hope to take away a lot of information. I'd like to take this time to introduce our esteemed speakers today who will be sharing their wealth of knowledge and expertise in the field of critical care. Dr. Gutierrez is an intensivist and the medical director of the CVICU and CCU at Baptist Medical Center in Jacksonville, Florida. Some of you may recognize him from his social media and his handle of Eddie Joe MD, as well as his podcast, Saving Lives. Our other speaker this evening, or this afternoon, is Dr. Sherman. Dr. Sherman is an intensivist at Torrance Memorial Medical Center, Cedars-Sinai in California. He serves as the chair of critical care, and he doesn't need any fancy introduction because he prefers for the content to do the speaking for him, and at the end of the day, patient care is what we're here for. So in this program today, we're going to be identifying and risk stratifying patients who may require support, explore key principles in patient management, and discuss the role of interdisciplinary team in device selection, weaning, and escalation. For more information about Impella products and our safety profile, please scan this QR code. So why are we here today? We're here today because of this algorithm. This was from the National Cardiogenic Shock Initiative, and it is a national algorithm that has been gaining acceptance and awareness regarding cardiogenic shock. This algorithm was the first of its kind in that it took a very sick patient population and determined a process for standardizing protocols and care for this patient population, which are those patients with acute MI at risk for cardiogenic shock. And with that, it brought together a team of people to take this very hard group of patients and come up with a systematic process to define outcomes and define a way to take care of them immediately and direct our care. Through this National Cardiogenic Shock Initiative, what's happened is that awareness, education, protocol development, standardization of care has enabled us to push forward our ability to save more people. And when we started this initiative, or not me, but the Detroit group started this initiative, we were seeing a 50% mortality rate. And now we're seeing a survival rate of 80%. And that's through standardized teams and processes, which I hope you will take away from this as the goal of having medicine today and certainly having critical care folks like yourself here. With that being said, we also know that the patients are changing in the ICU. And from the CTTN database, we were able to figure out that 33% of patients being admitted into ICUs today have cardiogenic shock and heart failure. And this is why we need to raise awareness and raise our knowledge and skills about taking care of these patients. For some of you, you may be familiar with the UNOS allocation changes in 2018, and we call it the rise of the machines. And the reason behind that is because with those UNOS allocation changes, we saw a growth in temporary mechanical support. And why are we seeing this growth in temporary mechanical support? Is because we know that it's going to impact our mortality and improve our survival across all of our platforms. However, we have a lot of work to do. We have increased awareness, we have increased technology, we have increased team-based medicine, but what we need to do is continue to push our envelope and gain knowledge around this technology. And that's because we have still so many patients who are having mortality associated with MCS devices. And if 10% of our patients are now in the units with mechanical support, then we have to raise that bar. We have to raise the bar about acute heart failure and our awareness regarding these patients. So if you take cardiogenic shock and take 5 steps back and look at acute heart failure, what you're recognizing is that all of these patients are coming in for one reason. Their heart's not able to deliver blood to their feet. And because of that, they're entering into our systems and our care teams, and we now have to work very rapidly to figure out if these patients have shock or not shock. Are they in a state of hypoperfusion? And if they are in a state of hypoperfusion, let's take them to the cath lab, let's take them to the procedural area, assess the patient, stabilize them, and then figure out what's really happening. And we have to do this in a team system. And why do we have to do this? Because once you enter a state of hypoperfusion, you're likely to enter the cardiogenic shock spiral, and that spiral can very quickly deteriorate to a state of death, in a state where you're not able to get back myocardial recovery. And that's why we have to move quickly and use these team-based approaches to take care of our patients. And with that, I'm going to turn it over to Dr. Sherman, who's going to speak more about how we can do a better job of taking care of this patient population.
Testing. Hi, everybody. Welcome. I'm going to speak a little louder. That light is very bright. And I want to thank everybody for being here. I think one thing I realize about everybody here, whether you're an APP, respiratory therapist, physician, administration, is that you all have two things in common. One, we're all human beings. We treat human beings. But you all have the part in common that you want to save lives, you want to make a difference. You know how I know that? One, the field you've picked, and number two, the fact that you're here and you're interested and you're excited about critical care. And so am I. Because the people we treat in our community hospitals, which I'm at a community hospital, are our neighbors, our community members, our friends, our family members, or they're somebody else's family members. And I've never forgotten that. It's our hospital. So why am I doing this? Why am I, as a physician with my other intensivists, doing this? Well, you know why? This is some of our data, our personal data that I can share. And the biggest point here, and it's hard to see, is that our survival has gone from 66% to 85% on AMI, using a shock initiative and a team, I'm just going to say people who are on call approach. Because what I don't like, as soon as I say team, everybody runs. Nobody wants to be on call more. Nobody wants to have the hassle of management of a team. But guess what? We're all on call anyway. The team is already there. So you don't have to really build it. You just have to communicate. So we've really moved all of our AMI and heart failure from 53% up to the 85, 90 percentile survival. That's real data at my hospital. I've seen it work. So what would you do? When I first started as a champion and understanding that we can do this at our community hospitals where we have the support, not everything has to go to a regional center, although we do ECMO, and so I felt like this. I felt like this guy running around the hospital, something's caught up here, running around the hospital like a rebel, trying to get people involved. So, it's a funny wig. I apologize for that, but it's real. I got to get this on good. Okay. All right. So here's the thing. When I started as a champion, yes, I'm on call a little more often. I'm running around. I'm saying, hey, ED doc, hey, my PA, cardiac PAs, we've got to do this, my interventional cardiologist, and especially everybody who works in the intensive care unit. You are on the floor, and I'm swinging from rope to communicate to you that we can do a better job. It's not what you do, it's who you are, okay? And that's what I feel, the compassion for doing this. I appreciate you putting up with that. So, here's the thing. What all of you do here is hard. And you have to change our culture. Years ago, doctors were endorsing cigarettes. We've endorsed a lot of things that aren't today relevant and may actually have been crazy. But this always reminds me, more doctors smoke Camels, right? Come on, that's a long time ago. So we've all been through hard things. What you do is really hard. We went through COVID, I think I remember it. It was a blur. ICH. We have to put in the chest tubes and people with hemotension, pneumothorax. ARDS. Aneurysms. So the things you do already as a team, as people treating these critically, is very hard. And honestly, doing mechanical support, working as a shock people in your hospital is a heck of a lot easier than the stuff we do, okay, on a day-to-day basis. So we talk about early myocardial infarction, catheter-based care, systemic thrombolytics. We've had stent studies from the 70s on. Now we have Impella devices. Hey, stroke, systemic thrombolysis, studies that showed we could put a catheter up in the brain and pull out thrombectomies, and we do that all the time now, thrombectomy capable or comprehensive stroke. We have venous thromboembolism. They pull out clots too. But the point is that catheter-based systems, microcatheter-based and catheter-based systems going into the body is nothing new. So this is nothing as us as intensive care doctors and our colleagues to shy away from. The future is now. Hey, these were a bunch of people on call with a heart failure patient, and all these people on call all of a sudden immediately act together and become a team. All of you are part of a team. Does anybody here not work with a team? Right? Do you call each time you're on service, okay, where's the team? Everybody knows you're already a part of a team. You don't have to make it up. All right, let's talk about ventricular involvement. Let's face it, hemodynamics are hard to get without the gear, okay? So I want to talk about early awareness, getting the thought and the culture change, because nothing in critical care is good if you do it late. I think you would all agree. I don't think any of us want to do it late, and we're desperately always trying to be as early as possible, because I think everybody here knows what happens when we get to the patient late. So we can talk about pre-shock, lactate, BNP, troponins, EKG changes, but we always want to think about early support and early initiative of our thought process. This is from Journal of Circulation, AHA, talking about pre-shock in 2022 and hypoperfusion versus hypotension. And a lot of us have been reading up on that. But really what it comes down to is I think we under-recognize the hypoperfusion when we're helping our colleagues out and thinking about those biochemical markers in what shock is. And a lot of literature is coming out on that. We know if the ALT is up and the lactate's up and your renal failure is getting worse, that yet even if your blood pressure is over 90, you're in shock. And that's what the literature is supporting, that you're in shock, you're hypoperfusing, and those patients do worse. So, with shock, of course, we're going to recognize these things. We reassess these cardiogenic shock at our hospital every 1 to 2 hours, and we're activating our heart and lab, cath lab, and heart surgery team. But, you know, in the ER, we trained our APPs and our nurses to really, they're on the front lines to looking at this cool, clammy patient. Is their blood pressure less than 90? You know, are they considering starting a vasopressor? Because as part of the cardiac people on call, as the intensivist, I don't want to know after you've started 2 pressors. I want to be called ahead of time. We need to get involved early, and that's what we've done. We've created a wonderful APP team in the ED that helps out, follows the patient through the process. Us as intensivists are in the initial consult with the cardiologist. We're getting in early. I want to be called when that lactate's greater than 2. If you're thinking about a vasopressor, my ED colleague sometimes is watching and taking care of everybody, any of you ED doctors, but you've got a lot of flow coming through, and it's nice to be able to know the intensivist is also involved getting that information. So, SCAI, right? All the stages. And we think about we start early, whether this patient crashes on the floor, PACU, in the physical therapy department, or even, of course, in the ER coming in. Hopefully, we try to get EMS on board here, but of course, there's A, B, C, D, E. None of us want to react when we're basically at E or D, right? Those are patients that are very, very sick, and we're coding them. We want to act at B or C. We want to get in early. So I don't have to go over these, but all these studies, of course, show the higher the score, letter, the worse you do. Plenty of studies over the years, from cardiogenic shock to patients in the CICU, outside of a hospital, cardiac arrest, okay? You know that. Well, here's a couple of things with the SCAI stages that I think is important that I like to initiate early and be the one escalating. Now, when I say the one, whoever it is one of my APPs, it's the nurses that are trained to do this, it's the docs, even the RTs can raise their hand. There is nobody that cannot speak up and say, I'm worried about the patient. So B, hypotension, blood pressure 60 to 90, MAP 50 to 65, lactate 2 to 5. When you think of hypoperfusion, ALT 200 to 500, but no drugs, no devices. But this is really important. This is where we should all be thinking and having the conversation with our interventional cardiologist, our cardiac surgeons, and our own people on call, and how we're going to handle these patients. Because you know, if that lactate is 2 and the blood pressure is 95, and we haven't done anything, often I'll do a consult and somebody says, well, how's the patient doing? Well, we haven't fixed anything yet. We got to fix it. So what happens if I don't think about this lactate at 2 and get the culture to change to know that in a few hours that lactate, if I don't change anything, may go to 4. And we know what happens. And then you go into multi-organ failure. So we want to act on B. We want to suggest, as people that are educated in all of the fields that we do in critical care, to our interventional colleagues, we're going to break down that brick wall, which we have done at my hospital. We get on the phone and have the conversations live. Hey, we're now in hypoperfusion. We are transitioning into C. I want you to consider mechanical support early to support a high-risk PCI or support the patient for unloading. And then you, as my interventional or my surgeon that's got to put in Impella, we can discuss what the next step is of the process and what we have to do today to unload that heart and then take care of the ACS. But that's a conversation that as intensivists, we're seeing the patient often live first. We drive the care for all of our patients, and this is something that we need to be actively involved, and it saves lives. Of course, D, lactate 5 to 10, E, we're in trouble, through those higher stages. But I want you to think about B and C. That's where you want to be called. That's where we work with all of our colleagues to say, hey, talk to us, call us. I see the shock on people on call team. It's for all types of shock. I don't know what type of shock's going to happen when they call me, but if I'm involved early, I can sure help early. Okay, all of these studies that Linda just went over, the bottom line is 50% mortality with standard therapy over the last 30 years has been there. When you create a system, and that system works together, just like other systems for early initiative, your survivability goes up, 82% in the INOVA, 71% in NCSI, the Japanese registry, 77%. So what this is important is more about the systems you create, and then adding the thought process with the SCI and having the advantage of every device and medicine and your pulmonary artery catheter that now I seem to be putting in so often that, went away for a long time, right? I'm back, until we have a better widget. The PAC gives us that data we need. Okay, here's a case. 66-year-old engineer comes into our hospital with a remote past medical history of a stroke. He has complaints of chest discomfort for 2 hours. Then he comes in. So he's got some shortness of breath, dyspnea on exertion, tachycardia, SBP 88, just like every patient you've seen. What does that chest discomfort mean? Well, he initially was I'm going to say, no one's comfortable when they come into the ED, but you know what? And then when I ask them how they're doing, they always say, I'm okay, doc. I'm okay. Well, then why'd you show up? I know why, because you're scared, but you don't want to tell me you're scared. And I'm scared for you. So we look, the BP is 85/60, pulse is 128. We get a CT chest, there's no PE. We see this is an end-STEMI, the troponins are up at 1476, our high sensitivity, our BNP's up. The lactate initially normal, and then it started to creep up to 2.2 in 4 hours, and then Levophed got added. Okay, so I would say with this tachycardia, and of course that blood pressure of 90, we were in shock. And I didn't need to wait for the lactate, but I would have been happy if it was the reverse. I would have said they were in shock if the lactate was already elevated and the AST was elevated and their urine output was down, even if that BP was 90 and that heart rate was slightly down, was chest discomfort. I would take it very seriously. So the intensivist at that time with a cardiac PA goes ahead and says, hey, this is hypoperfusion in transition, calls the cardiac team on the phone. They're talking to the phone. The intensivist is with the interventional cardiologist, with the surgeon or the cardiac surgical PA on the phone, on the speaker saying, hey, this is what we're going to do now. And we've never formulated a team. It's just because we're all on call. So we decide that the patient, as they decline, we're going to think about escalation even to the 5.5 axillary. Right? We got to have that conversation now. I got to know how far am I willing to go and how much do I need to unload this ventricle, okay? Having the conversation up front is the most important thing we can do with our colleagues. Let's talk about it. And we may not always agree, but we have to have the discussion because then we'll know what happens at 2, 4 o'clock or, as usual, 3 in the morning. Okay, here's our ST elevations inferior. I think everybody will agree that's ugly. All right, here's access to the groin, so we brought the patient right back to the cath lab. And as the intensivist, if I'm able, I will follow that patient, or my PA or APP will follow that patient. So does anybody know what this device is here? Well, you probably know because of the slide. Any takers? Any? That's the Lucas. That's the machine doing CPR because that patient went down. I hope none of you are flying 737, 9. But the problem is that patient went down and crashed and now is on CPR. But guess what? That's moving up and down. My cardiologist gets in there, places the Impella to support this high-risk patient and able to support to do the PCI, okay? I even prefer to, I wish we'd get to this patient even earlier and been able to predict. We don't have a crystal ball, but our job is to try as best as possible. Okay, so we get the catheter in there, open up that RCA, remove the Lucas. The patient, actually with the Impella, the patient started having forward flow and we stopped the CPR. It was great. And then able to get the PCI done. We decided at that time, because we had a conversation before, and most of the patients don't need this. We decided let's put them on VA ECMO for a couple of days, okay? But that's how far we took it in this crashing patient. But most of my patients don't need that, so they just need the support. So after that, the lactate peaked at 4, normalized within 24 hours. The thing about the hypoperfusion versus just hypotension, these patients do worse. They go into other multi-organ failure. This patient ended up getting a cholecystitis, had a GI bleed, acute kidney injury, all of these things, but they resolved because we continued the support as early as possible and continued it. So the echo looked better. Everything got opened up. Our CPO, our cardiac power, which should be 0.6 or greater, was 0.92. So we knew we were ready to start de-escalating. So keys to success, even on this difficult patient, rapid identification by intensivists, APP, early mechanical support, multidisciplinary decision making. Okay, we're already there. Discuss the case on the phone. You don't, necessarily need some fancy thing. Just get it done. You already call everybody, right? Does anybody here, have a special operator that puts you together on a conference call? No, you just get on your phone and do it. Okay, think about SCAI stages early. It's great evidence. They just updated it in 2022, right? This is your guide to thinking. But nothing's going to ever tell you what to do. You know the variables of the patient. That's our job. But we have the support and the evidence to do that. Minimizing use of vasopressors and inotropes. Here's our protocol. We have our own protocol, okay? And it's a work in progress. So in the ED, we get our labs, our biomarkers. We look at the blood pressure, it's less than 90, MAP less than 65. Do they need vasopressor inotropic support? And this is something that we did at our hospital. So, and in whatever your hospital works, you can do one for yours. We're all we all have different types of patient populations. So then we have some ED to MD suggestions. So now we call the interventionalist, we call the intensivist. Now, starting this program, hey, a couple of us were champions. We helped build the program and we're available. So that's why it has my colleague interventional cardiologist name on there. And I just told everybody I was available. So, and then we look at best practice and we go to the cath lab and we get our cardiac index and our PAPI and we get the CPO, we get the SWAN numbers. We want to know, what that wedge is. So all the things that we were trained to do as intensivists and all our other colleagues, we interpret, we get all this information in the cath lab, and then they end up in the CV ICU. And we're repeating our labs generally every 4 hours, just like we do on other sick patients. And we follow those patients to make sure that we're reversing the situation. And, hey, this patient ends up in our ICU with a CP. Guess what? We're following these so closely that we know that we may need to escalate. We don't want to hear anymore that we've added the second and third pressor because we know that's harmful. We know that we have to think, what else can we do? So, quick case. Okay, 72-year-old female, chest pressure, once again, this one's in the ER. I go down to see her myself. How are you doing? I'm okay, doc. But clearly not. You can see these people. We're resilient. Every chest pain is the burrito I ate last night. So we're the human nature, even us all in here, right? It's kind of hard to admit. But she's in there, SBP at 90, pulse at 100, some lateral ST depressions. Lactates 2, troponins 2,000, 4 hours later, because we were on it early. We were already having the discussions with our interventional team, and we're getting the labs on a system-based every 4 hours. Now the lactate's 5. All of you would say now we're in trouble. The markers are up. Okay, now, guess what? That EKG changed. Now it's ST elevations, a pressor has started. But as this was evolving, guess what happened? This is what the slide doesn't tell you. The patient was transported to the ICU. And of course, this was at 3 in the morning. So at least we had the system and our team on at night, which was part of me, I was on that night, was able to catch this because we saw all of these coming up. But sometimes the patient's already en route. It's like, oh, it's an end STEMI, they're just coming to the ICU, we're going to cool them down, and then they heat up. So that night, called the interventional cardiologist, also called the cardiothoracic PA, alerted them the need for a potential 5.5 larger Impella, because my concern is not where we are now, where I don't want to be later with multiple pressors in multi-organ failure. Lactate, so we did a protected high-risk PCI. Got the Impella in there, supported the patient, helped vent that left ventricle, provided flow of 3.5 liters a minute, and guess what? The lactate comes down. Amazing. Flow and perfusion means something. Troponins are sensitive. They had gone up, they went down, and this patient's pH was 7.3, PCO2 at 29, PO2 87, and bicarb was 19 on 6 liters. So this early wasn't showing me the acidosis that we see a lot of patients have, but some of the other, that lactate was really important to me, and how the patient looked clinically, the cool, clamminess, a lot of that physical exam that we do as intensivists, but we need to do it early. Okay, echo 25%, wedge went from 22 to 14. Patient was discharged home 3 days later. So early support. Early support, they go home in 3 days, we take it out, they do better, we save that, avoid that multi-organ failure. So, thank you. I'm going to pass this on. And here you go. I want you to remember that it's okay to start as a pirate, but then you're going to end up being very organized and you're going to save a lot of lives. That's what we do. All right, thank you.
Oh, there. Just make sure. Okay, perfect. That works. I don't have a wig. If I would have known he was going to do that, I would have just done something differently, not been just boring. My name is Eddie Gutierrez. I work at that hospital. It's very pretty in Jacksonville, Florida. It's a community hospital, 500 beds. We do a lot of good work there. A lot of good work. I'm privileged to be here in front of you all. I'm also happy that my partner, Vishal Singh, is right over there. We do 7 on, 7 off, covering with each other. So if you think anything I do is or say here is a lie, you can just double check with him. The other thing is that we're both here, so I feel sorry for the patients who are at my shop right now. Nonetheless, I'm an intensivist, and I just love taking care of patients who are sick, and hopefully we could pass forth some information to you all to help you better manage your patients at your respective institutions. So the big thing about managing patients with cardiogenic shock, as both Brian and Linda said, is that the mortality is 50%, right? And this is across the board. Don't feel bad if your mortality rates are 50% right now, because that's what has been historically since the 70s and even before that. But what we want to try to do is start these protocols that really we don't have to reinvent the wheel. I don't use a fancy protocol that I created. I'm not that smart. So what I did is just copy what's already been done, right? And you just have you just replicate what has shown this improvement of survival from 50% survival up to 70 and 80% survival, which is where we're hanging out at my institution. I don't have my numbers, so can't fact check me on that. But we have this actual table laminated up in our ICU. And I say laminated just in case Jaco's here. I don't want you guys getting mad at me. It's actually laminated. So, but you see this protocol, it has a bunch of words, you're squinting at it, but we just need to break it down, right? It's not that hard once you start looking at the components of what the actual protocol says. And these are patients who come in with acute myocardial infarctions and they go into cardiogenic shock. Sure, easy enough. But these patients, most of the time, are going to go to the cath lab before they even come to us in the ICU. And then our interventional cardiology colleagues are going to do their intervention. They're going to open up the vessel. And at least at our institution, they reach out to us before they put in an Impella a good amount of time, or a balloon pump, or whatever type of mechanical circulatory support. But there are some components that, as ICU physicians, APPs, part of the team, I'm saying the team word, but there's some things that we are responsible for and things that could help improve patient management and hopefully patient outcomes as well. And it's the utilization of a right heart cath, which is coming back from the dead, as we all have been seeing in our respective practices, and the utilization of CPO and PAPI to help you manage the patient so that you're not flying blind in just looking at lactate or looking at just one parameter, because that, unfortunately, is not the way things work when you're taking care of these patients. So the question is, do our patients need a swan, right? At our institution, Vishal and I, we float swans all the time. We've even trained the APPs to float swans. It's just part of the practice. Somebody's in cardiogenic shock. We have an agreement with our interventional cardiologist that they should float the swan since they're already there. They got fluoro, but they don't, right? Like you try to do it, but they don't really do it. Sometimes it's late, the cath lab team is there like bumping them on the shoulder saying, hey, we want to go home, it's 3 a.m. So when they get to the ICU, we place the introducer, float to SWAN. But people will tell you about the ESCAPE trial. They'll say, oh, but the ESCAPE trial showed that there was no difference in mortality in patients who had decompensated heart failure, and so why are we doing this? Well, the thing is that if you're academically honest with yourself, you know that the ESCAPE trial did not enroll patients in cardiogenic shock. So everybody who comes up to you and says, oh, but there's no data to show that there's an improvement in mortality. Well, sure, there's no randomized controlled trial, but there are a number of observational retrospective trials that do show an improvement in patient mortality. So this is a tool that is a little bit older, but at the same time, it's still very, very useful to help us manage our patients. So how could the SWAN help us manage our patients, right? We have this device, we have to know how to use it and what to do with the data that we receive. And this is where the CPO comes into play, the cardiac power output. This is something that we calculate all the time, every 4 to 6 hours, depending on the acuity of our patient, to help us decide if the patient is doing okay, if they need to be escalated, or if they need to be de-escalated. And the formula is quite simple. I know, I can't divide by 451 in my head either, but I'm going to show you how to facilitate the calculation of this, not to mention that there's an app for that. So, but CPO is map times cardiac output divided by 451. But you might say, Eddie, why are you talking about CPO and not any other hemodynamic parameter? There are so many different hemodynamic parameters that are sexy and like, you know, people talk about it and you were supposed to know what they mean, but why just this one? And it turns out that they looked from the shock trial registry and they saw which one of these hemodynamic parameters that, you know, there's a bunch of them and you have to squint at it to look at it to see which are the different ones. But the cardiac power output was the one that was the strongest independent correlate of in-hospital mortality. So it was better than like just looking at cardiac output or cardiac index or all these different parameters. So that's why CPO was chosen. So what's our CPO target now that we're going to be using that? And the number ends up being 0.6. This goes back to what was described before of 50% mortality, right? And they found that patients, if their cardiac power output was 0.6 or higher, the mortality was less than 50%. So if your CPO is 0.6 or better, pat yourself on the back because the patient's hopefully going to survive, right? Better than 50%, that means better than average or what it has been historically. So it also populates on the actual console for the Impella, so you don't have to go ahead and calculate it yourself. Our nursing staff, we work with a great team of nurses. They go ahead and they plug in the numbers from the PA catheter into the device, and it calculates it for you. So that's my finger there, by the way. So the way you can actually get to that menu is that you click the little menu button that's listed there. You toggle it over to where it says enter cardiac output. You put in what the cardiac output is, and then you hit enter, and boom, you got a CPO. It's not that hard, right? So you don't have to divide by 451. So we all feel good about that. So that's the assessment mostly to see how the heart function is globally and how the LV is doing, but then how are we going to measure the RV? And this is where the pulmonary artery pulsatility index comes into play. This is also a reason why you need a SWAN. By the way, the way that people talk about this is they call it the PAPI, and my dad joke is that I'm Cuban, so I call it PAPI. So, but that being said, the calculation for that is the PA systolic minus the PA diastolic over the right atrial pressure. So normal PAPI or PAPI is 0.9 or higher. Some literature says 1. You know, we're just we're going too nuanced there. But if the PAPI is greater than 0.9, then the RV is likely doing okay. If the PAPI is less than 0.9, then the RV is struggling. So you might need to consider how you're going to support the RV. An easy way, and sorry for all the waveforms that don't look correct there. It wasn't zeroed out. I took that on the spot. But you can look like a genius if you walk into the room and you say, oh, 42 minus 27, that's public math, 15 over 13. That's greater than 1. Okay, PAPI's okay. Right? It's not that hard to quickly make an assessment based on the numbers from the PA catheter as to whether the patient's RV is struggling or not. And compared to other hemodynamic parameters, it's the one that's the most sensitive and the most specific. So that's the reason why we use CPO and PAPI for these patients. So these patients go to the cath lab. They come to us in the intensive care unit. We do a lot of face-to-face handoffs with our interventional cardiologists, but they like to stay in their little basement. So the nurses and the team from the cath lab come up, and we have a face-to-face chat with them and a handoff as to what took place, et cetera. But when that takes place, we're there at the bedside. And what we do is that we make sure that the insertion site looks okay, there's no hematoma, that the interventional cardiologist didn't like pull a fast one on us. We make sure it looks okay. We make sure that if it's a CP, that there's a little inclination on the actual catheter itself. This is an example of a direct cannulation in a patient who underwent cardiac surgery. Here's another patient who had an axillary implant of a 5.5 Impella. So we make sure the insertion site looks good, no hematoma, no issues. We also check the extremity because you are occluding a pretty big vessel, right? At the end of the day, you want to make sure the pulses are there. You want to make sure it's not mottled and blue because then you send them right back. And you also want to check whether the device is locked so that you have that in your mind, you document that in your note because things tend to migrate. If you turn the patient, some things happen a little bit aggressively and you don't really want to, you want to know what the baseline was for the actual catheter itself. You'll check the P level, the purge flow, the Impella flow. Make sure everything is at its baseline and where you're starting off with on this patient. Chest x-ray, of course, to make sure that everything looks good with the positioning, the waveform of both the Impella as well as the PA catheter, because you want to make sure everything is zeroed out appropriately, and a transthoracic echocardiogram. We're very fortunate at our institution that we have echo techs readily available, and when you call them to the bedside, they'll just come by and hang out with you. The cool thing about that is that even though I say I know how to do echoes, the echo techs crush it in finding good windows. So I make sure I'm there to see where they're finding the best windows so that then I could come by and remember where it was. And it makes me look like I know what I'm doing. So anyway, so then the order sets usually talk about the serial labs you should be checking on people. Q4 or Q6 hours or Q8 hours, depending on the acuity of your patient, is how often you should go ahead and do these, which include the CBC, the BNP, lactate levels. You want to make sure that clears. Also, LDH or plasma-free hemoglobin. We'll talk more about that later, and other coagulation tests. From a daily standpoint, make sure that the liver is perfusing, their PTNR is okay, and the electrolytes. Want to make sure all your electrolytes are as perfect as possible. But one thing you should watch out for when you're doing these Q6-hour labs is what's called the vampire effect. I'm coining that. I haven't heard anybody else say it. But basically, this is a patient at some other institution who started with a hemoglobin of 12.5, and they basically got vampired down to a 7.9 because of the serial labs because they were very unstable. So, try not to do this. That was somebody else. That wasn't me. It totally wasn't me. That wasn't my institution. So from an imaging standpoint, daily chest x-rays and echocardiograms are performed in these patients. Sometimes that the echo tech isn't available, we go ahead, drop the probe, make sure everything looks okay, the positioning is okay, and just go from there. But every single device has its own complications. So we need to go over that because when these problems arise, we're the ones who are going to be at the bedside ready to respond to it. First thing is bleeding, right? If you look at the systematic review and meta-analysis, it will tell you that the bleeding risk is 20%. 20% of patients have major bleeding. But this is taking into account older data. We've gotten so much better at cannulation, at anticoagulation, and things of that nature, so that now the more recent data from last summer are showing transfusion rates of less than 3%. So we've been improving with our repeated management of these patients to avoid bleeding complications. Something else that we've changed in a lot of our institutions is the actual purge solution, which used to be heparin, but a lot of us are using sodium bicarb now to actually run the device. And the data from this, it comes out of Orlando, but it shows no difference in thrombosis outcomes when you use bicarb versus using heparin. And in addition to that, beneficial, less bleeding in the actual bicarb group. So things to take into account, if you're still running heparin in your Impellas at your institution, it might be time to change over to the bicarb. Another complication that happens quite frequently is actually hemolysis. And there are a number of reasons why this happens, and this incidence of about 10% turns out to be pretty accurate. That's what we all see at our respective institutions. The thing that could help us out with hemolysis, first of all, is identification. Don't wait until the urine is red, for lack of a better term. You want to try to catch it early, and so you're going to be trending either LDH or plasma-free hemoglobin. Pretty much every institution has LDH right now, but plasma-free hemoglobin is something that's becoming a little bit more available. We've had it now for how much, Vishal, like about 6 months or like just about. So we're becoming more familiar with what the normal numbers are with this, when we should let it ride, things of that nature. The advantage of plasma-free hemoglobin over LDH is the fact that it has a much shorter half-life. So you can make an adjustment on the actual catheter, the adjustments that I'm going to be describing shortly. And then when you do your recheck of the plasma-free hemoglobin, you'll see that it either dropped, or if the intervention didn't work, you'll see it keep on spiking up. Versus LDH, you kind of have to wait till the next day for that to start clearing up. But when you do have hemolysis, first thing you need to do is make sure that the position of the catheter is okay. It's not up against the wall, it's not up against the leaflet, that it's where it needs to be. You also want to make sure that the fluid status of the patient is optimal. One of the things that's been quite curious in taking care of these patients who, a lot of them you think they're just like volume overloaded and things like that, they become pretty preload dependent, and you actually have to give them volume even though they're in cardiogenic shock. So it's just something that happens, and you'll notice it in your practice. So if the patient is dry, they're going to have hemolysis. You give them a little bit of fluids, and you'll notice that there's an improvement there. One other thing that you need to do is go ahead and decrease the P level. You want to decrease the amount of pigment from hemolysis of the red blood cells because you don't want to cause an AKI because of your actual device. And then last but not least, something else to take into consideration is that you just might need to go ahead and escalate the device from a CP, for example, up to a 5.5, which has much, much, much less hemolysis. Okay, in fact, I have not seen hemolysis with a 5.5 Impella. There is this algorithm, which if you're going to take a picture of one slide, this is it, because I'm not going to go through it. It's a pretty busy slide. But basically, it gives the protocol for improving management of patients who are currently hemolyzing, which include doing the echo, you reposition the device, give them fluids, you try anticoagulation on them, and then chances are you'll have to go ahead and upgrade them to a 5.5 Impella. So something else to watch out for is limb ischemia. This is something that takes place in about 5% of patients, although we are getting much better at this. You know, the interventional cardiologists are becoming far more savvy at actually measuring the vessel and see if it actually fits and if they're going to be displacing plaques and things like that. So the incidence of that is 5%. And don't forget to do neurochecks, because some patients do unfortunately have CVAs. So if you have a patient who's in cardiogenic shock, they're sedated and intubated, please wake them up. You want to catch them in case they do have an unfortunate stroke, which the data says takes place in about 4% of patients. Now, the console has all these squiggly lines, you know, that we have to know what they look like as normal to fix them when we start having some issues. So we have in red, which is the aortic placement signal, and then the LV placement signal is the LV placement signals, this one in gray right there. And then you have your motor current, which you get used to the numbers depending on whether you have a CP Impella or whether you have a 5.5 Impella, which runs with far, far less power. Because what happens is that alarms are going to be inevitable. You're going to start having alarming and people are going to panic, but there's no reason to panic because the machine will help you out. What I mean by that is a type of complication, a type of alarm is a suction alarm. But the good thing is that when you do have these complications or these types of alarms, the device will actually tell you what to do. So reduce the P level, check the filling, check the placement, things like that. The machine will tell you what the issue is. But what actually causes these suction alarms? Because a lot of these things could be avoided, right? If the patient has an adequate LV filling, they need a little bit of fluid, then that could cause a suction alarm. If the position is incorrect, if it's hitting a wall, if it's hitting a leaflet, if it's stuck in something, then that's going to cause an alarm as well. Or patients who have RV failure. That could also, that's why you need your PAPI, because you could kind of see what's going on with your PA pressures and your CVP and kind of predict if somebody's going to go into RV failure if they're not in RV failure already. So let's make this simple. Let's go ahead and fix these suction alarms. First thing, as the machine said, reduce the P level. Okay, simple enough. Do your echo, check the filling pressures and your volume status on your patient. If you might need to do a small fluid challenge to see if there's any change, then go ahead and do so. And you might need to reposition the device. This is something that initially there was a lot of resistance from intensivists to be tinkering with these devices, but that's something that we need to be able to do. Like both Dr. Singh and I are people who reposition the device whenever it's necessary. We've even started training our APPs to reposition the device as well. So that's just part of our workflow. So this is a case of a patient who, if you notice, they're starting to have their LV pressures, their LV diastolic is pretty darn negative over there, right? But you also notice that there's that little inflection here on the actual LV waveform, and you're having a suction alarm. This is what's called diastolic suction, okay? This is a patient who's, If their CVP is low, if it's less than 12, then you need to check the volume status on the patient. They might need a little bit of fluid. But if their CVP is greater than 12, and I really hate using CVP absolute numbers because patients are so different, whether they're on mechanical ventilation, not mechanical ventilation. That's why you have to know your patient. But if their CVP is elevated, well, then your RV might be down, and that's where your PAPI will be very helpful to see if the patient needs right-sided support. This is a case where you see a decoupling of the aortic waveform and the LV waveform. They completely separated. And this is what's called continuous suctioning. This is a patient who needs their positioning of the device actually changed or like relocated. This is why it's very helpful for ourselves as the clinicians at the bedside to know where the windows are so that we could get a good view and see if the device needs to be relocated. You know, something I did last week was I found the window of the patient. I had the nurse just hold her hand right there, and I just changed the location of the catheter. It doesn't take rocket science. You don't have to get an interventional cardiologist to come upstairs. You just go ahead and fix it. Once you get comfortable at relocating the device, it's pretty intuitive. Here's a case where the aortic waveform, where the LV waveform looks just like the aortic waveform. So the Impella's in the aorta. It's not so bad, right? On the contrary, you don't have an aortic waveform. You just have two LV waveforms. That means that the device is actually in the LV. Hey, so you go ahead and you pull it back a little bit. See, these things are not that hard. Once you start becoming more familiar with it, start tinkering with it, developing more experience, you're going to be able to take care of these patients without being intimidated by all the machines and by all the sounds and all the alarms. But there's always this low pulsatility. And this is where you have that complete decoupling, and the aortic waveform looks pretty flat and the LV waveform looks pretty shallow. So when this is taking place, this is a patient where you first need to check your own pulse because, you know, don't get scared. This is why the patient has an Impella in the first place. They're in cardiogenic shock and they're not. Is it getting romantic in here? Am I running out of time? Is that why they're turning off the lights? Oh, okay, cool. Just making sure. Anyway. But basically, this patient needs the device, and the machine is actually supporting them, so that's why they have this particular waveform. So, you know, do your echo, assess the patient, make sure they're alive, make sure you're alive, and then move forward with the management of the patient. So, and sometimes it says Impella position unknown, so that's always fun. So, but is our patient adequately supported, right? Because we're doing all these interventions on our patients to save their life. So how do you know if you're doing an okay job? Well, you touch your patient, physical exam. If they're not cold and clammy anymore, their jet fuel is coming down, you're weaning off the vasopressors and inotropes, because again, that's what you want to do. You want the machine to do its job. You want the machine to support the heart entirely so that you don't have vasopressors and inotropes increasing myocardial oxygen consumption and not letting the heart recover from all this. Their mean arterial pressure will hopefully go up, their mixed venous will be better, their CPO and PAPI are above the target levels of 0.9 and 0.6 respectively, they're starting to make urine, they're clearing their lactate. These patients are doing well, right? Like you have them appropriately supported and you just let them coast. So, but our patients don't always do well, and some of our patients are struggling. So when do we need to go ahead and escalate to a 5.5 or Impella or something else of that nature, something a little bit stronger? Well, on your physical exam, things are not improving. You're still cranking up, you're not able to wean the inotropes or the vasopressors, or you're even having to go up on these, well then you need to get out, you need to bail, you need a new strategy. If you can't improve your MAP, if your mixed venous still looks bad, if your PAPI is less than 0.9, well then you might need RV support. If your CPO is less than 0.6, you're gonna need to either crank up the P level or find a bigger device. If they're not making urine, if they're not clearing their lactate, well then you're gonna need to do something different, because just waiting around and praying that things are gonna get better is not gonna make it better. I mean, that's why these patients have such a high mortality rate. You can't just sit on them. But you also have to know your institutional limits, right? My institution does not have ECMO. I do not want to transfer to my friendly neighborhood other hospital that helps me out with those patients. I don't want to transfer to them somebody who's irreversible, right? So you want to have a good line of communication with other institutions that have more resources than you. But you also have to have a very upfront conversation with patients and their families as to what the prognosis is with these patients. Because generally between 3 to 5 days with the CP, now we're experimenting with longer durations with the 5.5 Impellas. But if things are just not getting better, the palliative care the palliative care conversation really needs to take place, because again, these patients from the get-go have a greater than 50% mortality. So have that all squared away. But let's say we have a success story. How should we go ahead and de-escalate on these patients? Well, this is where your CPO and PAPI calculations come into play, because you want them to be completely off of vasopressors and inotropes, because when you take out the device, you want to be able to have a safety net of sorts. You want to be able to start them on something, like in case they need it, at least for a little while. Hopefully they won't need it. But you're going to notice that their CPO is greater than 0.6 or 0.8 when they're on P2. You notice that their PAPI looks good at greater than 1.0. Their organ dysfunctions are improving. The patients are making urine. The patient's liver functions, LFTs are finally getting better. And again, they're off of the vasopressors and inotropes. And also, when you're doing your daily echocardiograms, you're going to see that the patient has improved function. So when you have all these things lined up, you're going to feel better about the probability of being able to get them off of their mechanical circulatory support. But wait, there's a screen on the actual console itself that will help guide you as to whether the patient could be weaned off appropriately. And on the top part, and I'll show you how to get into the screen, and your friendly neighborhood Impella rep will also be able to help you with this. But you do see that the patient has a stable MAP and a stable LV EDP. That's good. You feel good about that. But then there's also this separate box which helps you assess for native heart recovery. And what I mean by that is that you're having tracings of what the Impella flow is, and you have tracings of what the native cardiac output is. And when you notice that there's a flip where the native cardiac output flow is superior to the Impella flow, you can feel pretty good that the patient might fly and might be doing okay. And again, you don't want to do this at P6. You want to bring it down to like P1, excuse me, to P2 or P3. So, and also these patients have a stable CPO and cardiac output. So this is the way I take selfies, by the way. But on a serious note, this is a patient that we took out the Impella that same day, where that patient was on P3. But you notice that the Impella flow was down here and the native cardiac output was superior to it. So we felt very comfortable. They weren't on any vasopressors or inotropes. We felt very comfortable in explanting the device. Here's another selfie. This patient's Impella flow was 2 liters, their native cardiac output was 3.5 liters. That device came out that day as well. So we're using this at the bedside as a final check mark of sorts to help us determine whether the patient's going to fly once we take out the device. So how you get to that actual screen, and pardon the dust, I mean, we do use this device. It's not just sitting in a closet. Is that you hit the display button that's located there, you toggle to the LV EDP cardiac output trend, you hit enter, and then you just have it just populates what the screen should go ahead and look like. So the bottom line with all this is, again, I'm trying to emphasize that you don't have to reinvent the wheel at your institution to take care of these patients. Once you become familiar with it, it's really not that hard. The protocols are already established. I could send them to you if you need a copy or anything like that, but we can make such a difference, as Dr. Sherman explains from his institution, the data that we have at our institution, that 50% mortality is hopefully something that we won't see ever again. And we could end up saving 70 to 80% of these patients who otherwise would go ahead and pass away. I mean, there's such an effort for patients who are in septic shock, where sepsis mortality is between 20 to 40%, depending on what you read. But mortality is so much higher in cardiogenic shock, but the training is still sepsis, sepsis, sepsis. And so everybody who has a lactate and who's tachycardic is getting 30 cc's per kilogram, right? Which is not going to be the best thing for our patients. But I'm going to get off my soapbox now, because I do want to wear the wig.
Yeah, go ahead.
Well, thank you so much, Dr. Gutierrez.